Hello, Andy. Meanwhile, I would like to discuss about the topic, which is post-thrombotic syndrome and the rehabilitation after that. Thrombosis, as every speaker mentioned about it, is developing a blood clot in the deep veins. Usually, deeper veins in our legs will have valves, which will direct the blood flow upwards. When there is a clot formation, and there will be inflammation, the walls become thin, and the valves inside the blood vessels will be less functional, reversing the blood flow and ending up with ankle edema. And when this thrombus is there for a longer period of time, there will be heaviness, itching, pain, swelling. Sometimes there will be ulcers. And the risk factors will be having a blood clot above the knee level and multiple blood clots and blood clots which were recurrent. And there are people on the hormone replacement therapy, people who are pregnant, obese, less physically active will be more vulnerable for stasis and the swelling and edema at the ankle. The best way to deal with prevention of the thrombus is always the best choice, and that needs the peripheral arteries, the calf muscles needs to be activated, stimulated, and when the calf muscle is working, it will help the blood flow, keep maintaining, and the ankle edema will be minimized, and the knee controls will get better. And the second best option is to have elastic compression where there will be sequential compression across the deep veins. And this compression enhances blood flow and reduces the risk of blood clots. Here, I would like to discuss, thank you, Andy. I would like to discuss a very interesting case. Marti ma'am, let's go to the condition of Mr. Manoj Lal. Interesting case of a patient who ended up with multiple complications. To next slide, please.
I have only this one and the case presentation.
And I think the slides are with Vidya, Andy.
Just one moment, I just have it here. I'll put it up.
Yeah, Vidya, can you please put it up? Yeah, this gentleman is Mr. Manoj Lal, who ended up with a very bad crush injury, who had massive bilateral frontal epidural hemorrhage, bilateral lung contusions, and he ended up with bilateral craniotomy, massive craniotomy, and he was on the ventilator for a very longer period of time. Despite being on ventilation because of massive craniotomy and removal of epidural hematoma, there is anemia, thrombocytopenia, aspirational pneumonia, metabolic acidosis, pulmonologist, nephrologist, critical care consultant, and all the intensivists worked hard. And there is very higher hyperpyrexia. He was on wider spectrum of antibiotics, dehydration, and he needed long-term ventilation. And the next slide, please. After 4 weeks of ventilation, He was still on hyperpyrexia. He was on 4 liters of oxygen. We can clearly see there was a massive deep vein thrombosis on the right leg, right upper extremity, and huge abscess on the left hip, which was draining. Under aseptic conditions, the abscess was drained, and now we have this patient in our rehabilitation facility. And at the time of admission, he was on 4 liters of oxygen, and he was on polybixene, meropenem, he was on TID, continuous secretions. He was having a continuous hyperpyrexia of 1 or 2 degrees at regular intervals. And now the challenge is, it's not just a DVT on one leg. He was dehydrated. He was on hyperpyrexia for nearly 4 weeks. His confidence levels are low. He's able to follow the instructions. His response was good, but he has an abscess on the left hip, DVT on the right hip, DVT on the right upper extremity. He is recovering from aspirational pneumonia, and he is recovering from metabolic acidosis, an exhausted man in our rehabilitation facility, where our consultants are requesting me to immobilize him for 2 more weeks. And our Guru Muralidhar Joshi sir mentioned, in the operation theater, if it is more than 6 hours, we will have stasis, muscle atrophy, and getting the pelvic tilts is difficult. Cardiopulmonary endurance is compromised. And then after continuous oral anticoagulation therapy for 2 weeks, we assessed the thrombotic burden with the help of ultrasound guided investigations, and there is no further progress of the thrombosis. I've got the green signal for further mobility. Next slide, please. And you see this gentleman without oxygen, allowed to sit and able to follow. We got the permission because the thrombus is cleared on the right upper extremity. He's able to move. But if you look at his tilt, he was massive anterior tilt, kyphotic posture. You can see elevated round forward shoulders, forward neck, and his cardiopulmonary endurance is massively compromised. We gradually improved his chest function, cardiopulmonary endurance, mobilized his upper extremity, got some pelvic tilts, and we are able to get him into erect posture, and there is no major hemodynamic fluctuations. So we got the permissions for further progression. And then we put him on the tilt table. And next slide, please. The tilting table is to encourage him and to avoid postural hypotension, because this gentleman was on the bed for nearly 12 weeks by that time. Gradually gaining weight, nutrition is helping, dehydration is avoided, and his temperature is gradually coming down. Then we have the luxury of having no pyrexia for nearly 2 weeks by that time. Saturations were better. He's able to cope with the vertical positioning, and he is much, much better, feeling confident. Now is the time for us to motivate him to next level, encourage him, because long-term effects, multiple complications, massive decompressive craniotomies, he needs a lot of encouragement. Next slide, please. And this is the way, a typical Indian game, caroms. Now you see his pelvic tilt is better. The idea of even recreational activity is to make him do multiple functional activities. Our focus is actually on his sitting posture, his ability to sit for a longer period of time without oxygen, keep moving around, and maintain a proper posture so that the lungs will expand to the best possible extent, and we will reduce the burden on the accessory respiratory muscle groups. And now he is much more confident, and we have planned for decanalization and able to get the control. And now he is able to write it and inform us what he likes to do and how he wants to do. The next slide, please. And see, this is how he started improving. You can see a confident man recovering from all the trauma, stress, burden, and now with regular strengthening programs, he is ready, up, standing, moving, and walking around. The first few steps. The final slide, please. The same guy who fought with every other system. Craniotomies, renal failures, pulmonary contusions, aspirational pneumonia, metabolic acidosis, weakness, DVTs, abscess, pyrexia for nearly 8 weeks. He's again on his own feet and walking around. Little longer, but we are happy to see him back. Thank you very much.
Excellent presentation.